in your head, then it is really difficult for you to make your patient's head clear, right? So because both of you and your patient are partners in a business plan, and the business plan or goal of that business is profit. And profit, I mean, how can you be profitable? To reduce pain, to reduce symptoms, to improve motions. That's the goal of that business plan. And to understand and to, you know, from point A to point B, you have to have a good grasp of foundational knowledge. All right, so hopefully I'll be able to touch the tips of the iceberg today, or the glacier today, to have you guys understand the nuances of active release techniques. So this is essentially the flow of today's story. What to expect today is nothing but content of a book. When you open the book, you try to read up the content, and today we'll go over a little bit of anatomy, a little bit of clinical characteristics, excuse me. Give me a second. Examination principles, diagnostic values, and treatment ideas. Lastly, we'll have question and answer sessions to end the webinar. Just so that you know, I know most of you have their chat boxes open. Have your questions ready. You can write it in a piece of paper or write it in the chat box for the moderator to compile each and every question and ask me at the end of the session. I always start with pictures, because to me, pictures, you know, present 1,000 words or maybe 1,000,000 words. What I cannot say verbally, if you see a picture, that will have more meaning to your mind to an understanding, you know, treatment strategies. So essentially, the basic premise means the principles on which ART lies. It's a hand-on movement technique. So basically, you have to use your thumbs, you have to use your index or the pointer finger, and maybe you have to use your middle finger. So these are the three, you know, appendages of your upper limb that you need to use to improve your critical thinking, judgmental capability for activities of to improve activities of daily living through the ART protocols. Also, the whole ball game realizes the fact that ART will help you to increase mobility through what? That's what we are going to discuss in the previous slides or the next slides that we are going to discuss. So essentially, it's a hands-on technique, these three fingers, and it helps to improve mobility. Now, this is a cool slide. I mean, I always, whenever I do workshops or webinar, I try to make my students and participants think. And by thinking, I make them understand what patients think and what the reality is. So what patients think or the myth is, oh, one more thing. I am not gonna read through all the slide content because it is for you to go over. I mean, it is on Facebook or it will be on YouTube. You can go back and go over the slide content. For me to help you understand from point A to point B, I'll tell you bits and pieces from the slide and then weave a story with that. And if you understand the story, the whole ball game basically relies on the philosophy of understanding the flow of thought. Okay, so I will be talking about very briefly whatever content is there on the slides. All right, so the first myth is soft tissues injured due to overuse. Yes, maybe, but that also is relatively new because it is also due to repetition. So more reps you do, more inferences it is for your soft tissues to be traumatized. Also poor body mechanics, and you all know that poor body mechanics actually is a sequelae to lots of signs and symptoms and pathologies and illnesses that you have come across, mostly mechanical derangement and dysfunctions. Also, myth number 4, overuse injuries only happens to athletes. If you go through research, you will see most of the overuse injuries are found in school students or adolescents or teens and preteens because they are extremely active, either in the school area or doing, playing sports and games in your localities and in the field, and they get injured because when we were young, we used to play in the fields, but we never used to exercise in general. Right? You are with me, right? So it is exactly the same scenario. that overuse injuries may not predispose instantly in that adolescent or teen phase, but may come across after 20 years, after 30 years. Then that trauma or micro trauma, repeated micro trauma, which was present during the school days, will eventually come across when you are an older adult, right? Then you have all heard about RICE, rest, ice, compression, elevation. But look at this picture on the right. So what he's saying is peace and love, isn't it? It's pretty pretty, right? By the words of it. And it makes you wonder as to what you mean by that. RICE is mostly done for any sort of injuries, but mostly skeletal or bony injuries. But peace and love is mostly related to soft tissue injuries that obviously includes skeletal muscles, to ligaments and tendons and other non-contractile units. So this is protection, elevation, and all the rest of the stuff. And it ends up with vascularization and exercise. All right, now, just because someone tells me to, listen to it, I do listen, I respect that, but I evaluate in my mind. When I am reading peace, this A is avoid anti-inflammatories. So like medications, and it says avoid taking anti-inflammatory medications as they reduce tissue healing. Avoid icing. I am not so sure about this. Have a qualified reasoning as this might be actually untrue. Obviously, this is a different, topic to discuss and to debate on, that do we need to avoid anti-inflammatory in acute conditions or not? My take is no, we should not. But again, that's a different issue to discuss on a different webinar or a different day. But today we are only focusing on ART, right? All right, so soft tissue injuries. Overall, to me, soft tissues essentially means non-contractile units, ligaments, tendons, cartilage, and fascia. Contractiles are skeletal muscles and fascia. Now, fascia, non-contractile, again fascia, contractile. What does this mean? So I am in US when I teach in the fall. I teach anatomy, and I have to prosect dead cadavers or dead bodies for my students to dissect them. So when I prosect, I have been doing this for a long period of time, like prosecting and dissecting cadavers for research as well as for academia. So whenever I cut the body, usually I start from behind, base of the skull. With the scalpel and with the bone saw, I essentially cut down to the tailbone, right? Because I need to rip open the skin from the posterior aspect. What I find and what mesmerizes my thought is fascia. Fascia is a network of structure that is present from the scalp of your head to the toes of your legs or foot, right? Toes of the foot. So essentially every inch and micromillimeter of the body is covered by fascia, and research on fascia or fascia, however you want to pronounce and say, is very less and very minimal compared to other sorts of research on neuromusculoskeletal system. So fascia, because it's a fibrous connective tissue, it's a non-contractile unit structurally, but functionally, since fascia is stuck on muscles, and with the motion of the muscles, the fascia actually moves, slides, glides, bends, kinks, and do whatnot the muscle is doing. The fascia is also doing that. So inherently, please remember, do not forget, with the hammer and chisel, etch it in your gray cells. Don't ever forget this. Fascia structurally is a non-contractile unit, but functionally it's a contractile unit because it again glides. Structurally non-contractile, functionally contractile because it is stuck to the muscles and it glides with the muscles, inherent nature of the muscles. All right, one more thing. Please, it's a 1-hour webinar. I cannot have everything of a 3-year program in PhD or doctoral program in US that I teach. I cannot have all the contents of treatments and anatomy, biomechanics, and pathology. I cannot have that in 1 hour. So In a nutshell, this is what I am saying. You might have questions and you might think, this is not there or that is not there. For obvious reasons, we don't have time, right, for that. So injury, I have in a nutshell, external, could be contusions, internal, could be overuse, myofibralgia or fibromyalgia, myofibralgia, whatever you say, or etc. Meaning that could be anything and everything related to mechanical derangement and dysfunction of the human body. So all these injuries per se can be treated by ART or the philosophy of ART. Just as a know-how, let me introduce you to this picture. As you can see, I mean, it's pre-injured to healthy tissues, but unfortunately in the healthy tissues, this white fibrous thing is nothing but scar tissue. And what does scar tissue do? It reduces range of motion and thereby it increases risk of re-injury. How does it increases risk of re-injury? The biomechanical principle suggests that when in a longitudinal structure, if the force passes parallelly along those fibers, doesn't matter, it could be bone, nerves, muscles, soft tissues, whatever might be the structure involved. If the muscles are this direction and the force is also along that direction, the structure has the least chance of getting traumatized. Unfortunately, in this case, because of the spider web-like structure, all the fibers are jumbled up. They don't have a proper place to move in any direction. Anywhere you stretch, they're moving in all directions. As a result, the rate of injury, rate or correlation of injury increases because of increased scar tissue formation. Unfortunately, scar tissue is a very, very jumbled up structure which does not have proper role or proper play within the other structures or between other structures, resulting in trauma or injury. Are we good with that? All right. So essentially, that's the rationale behind why there is risk of re-injury right over here. And obviously, it will reduce the range of motion because it's a scar tissue. It causes adhesions. Adhesions not just to the bone or joint or cartilage or ligaments, but also within fascias, with nerves, with vasculature, and obviously muscles will take a huge important role. So everything is entwined. Everything is entwined within the scar tissue, making it very difficult for it to move about within the space of the human body system. All right, so let's jump to what you were waiting for. Active release techniques or ART. So moving forward, we'll just talk about ART or ART. ART, as you can see, is a form of myofascial release. Voila, well, that you know, right? In fact, Dr. Lehigh, who was a chiropractor, was the founder of the principles of ART. In fact, in 1985, when he published the paper of ART, he actually named this as MFR or myofascial release. Afterwards, when he found that, oh my gosh, it has good, take by all chiropractors in America, he later patented itself under his name as ART. So most chiropractors in United States of America use active release technique as a form of soft tissue release. Got it? Now, ART, by the help of Dr. Lehigh and other chiropractors, in the past 20 years or so, have developed more than 500 motions
Yes, yes, no sound, no sound. Wait, wait, wait. Please wait for sometimes. I think a minute. Some technical issues. Just wait for 1 minute.
Yeah, he is connecting again. Sir, please unmute yourself.
Yes, ma'am.
All right. So I am so sorry, extremely sorry. I just don't know, something just crashed and everything blanked out. So apologies from my end. Let me go ahead and start one more time so that you know, hopefully you did not miss anything. So what I was saying is essentially ART is a philosophy propagated by Dr. Lehigh, who was a chiropractor, or who is a chiropractor, and he patented the ART later on around 2000, not 2000, 1990, 1995. And then what he did was essentially talked about 3 levels of courses that ART organization or activerelease.com or .org organization basically follows, and it is propagated all over the world. I think they do courses also in India. I'm not too certain about that. They have 3 levels, and then they also have advanced courses. But overall, they have 500 motions for soft tissues and close to 80 protocols that they follow or we follow in terms of active release technique. So overall, it is a form of myofascial. So what chiropractors do, in fact, in America, most chiropractors, over 80% of chiropractors follow active release technique as their go-to tool, to release soft tissues, to improve extensibility and flexibility of soft tissues. They usually use ART principles. So it is essentially arguably the most refined, advanced myofascial release technique, or MFR, currently provided in the world, or school of MFR. So essentially, what is ART? ART is nothing but you are manipulating and restoring functions of the joint, of the soft tissues that is pathological or that has problem in the range of motion, problem in pain and tenderness, and other symptoms are present, right? Usually, what it does, why is it so important for chiropractors, is it uses active principles. And you know that when you are doing active motions, that is extremely important for your brain or for your patient's brain to remember the pattern, because then you're using the fundamental principles of motor control, right? And you know that motor control center, MCC, is in cerebellum, but it controls the frontal cortex in terms of processing and learning. So active release techniques, lends a little bit of that motor control phenomena or postulates and uses active motions from patient perspective to improve that art or improve that technique of releasing soft tissues. That's basically it, okay? So what it does, it has more long-lasting effect, because whatever you do passively, I also do high velocities. I'm an osteopath, right? I do high velocities like chiropractors as an osteopath. But I know it may not last long. So to help last long, I do ARTs and muscle energy technique to improve patient feedback and to improve the outcome of my patient goals and aims in PT or in the pathology. Now, it is said that it helps to break up scar tissue and adhesions, but it also promotes blood flow, and that probably, helps in faster healing. Now, I have a little bit of questions on how it improves blood flow. I know it improves the extensibility of the vascular supply or the epithelial layers. I get it, but maybe because of the extensibility or the stretching factor of the epithelial lining of the blood vessels, it is helping to improve the blood flow. And obviously it's a soft tissue technique. So when you are compressing and relaxing, there is a pressure difference or pressure change that obviously will lead to propagation or improve or increase flow of any fluid, whatever that might be. It could be lymphatics, it could be obviously blood and other fluids too. Most effective, as been told by Dr. Lehigh, is for fascia, number 1, number 2, skeletal muscles, and lastly, ligaments and tendons. So what you note is This is not used for any bone pain or joint pain. It is not primarily used for any pathologies that has bone pain, or joint pain is the primary cause. ART does not have that much of an outcome or effect. But if it is related to any soft tissue, skeletal muscle, fascia, non-contractile unit, ART is really a go-to in terms of releasing those soft tissue structures. No, what are the benefits? You can go ahead. I'm not going to talk about everything, but what it does, two things. Look at bullet point number 3, improves fascial glides. To me, that's exceedingly important. Fascial glide is really primarily important. Even before I do my, osteopathic and chiropractic techniques on, if my patients or clients, I use ARTs or MFRs to improve fascial glides, because I know that if the fascial linings are stuck, I will not be able to generate the outcome that I am aiming for with high velocities. I will not. So my go-to for the first thing from my osteopathic standpoint is improve fascial glide. Okay, fantastic. I'll do ART or other MFR techniques like ISTM tools to release the soft tissue linings first. It also assists in maintaining soft tissue collinearity. What do you mean by collinearity? Collinearity is fundamentally a physics principle. So what it means is, for example, let's say we have skeletal muscles, and skeletal muscle cells are myocytes, right? Myocytes. So with trauma, myocytes will not be aligned because there is a trauma. So they will be completely jumbled up. So that jumbled up thing will not help in proper extensibility and flexibility of the soft tissues. But instead, what it will do, if you do ART, that jumbled up thing, again, this is an hypothesis, assumption, a presumption that jumbled up thing will be again normalized. So all the myocytes in place are linearly oriented. And when all the myocytes are linear, it is called collinear. As a result, it is supposedly helps in soft tissue collinearity. And I said, remember, I said soft tissue. So it also includes ligaments, tendons, and cartilage. So obviously collagen tissue after a trauma and tear, if they heal, and you know that it is quite difficult, but if they do heal, if you have a lot of scar tissue and adhesions, this could help to release a little bit, or superficial lining could again be collinear. Again, take it with a grain of salt. You may achieve it or you may not achieve it. But over 19 years of experience or 20 years of experience, I have found good results from ART principles though. And again, vascular and neural extensibility, it is obvious because vessels and nerves are entwined or intertwined with the adhesions and scar tissues. So when you release the scar tissue, the nerve flow, the pathway, the vascular pathway will also be released. Okay. All right. Conditions. You go ahead and read about it. I'm not going to talk about it because this is nothing different or new. All right. This is where it is important for you to understand. So please focus. Give me 5 minutes, focus on this, and then you can start eating probably, okay, if you are. All right, examination approaches. Now, ART is for soft tissue release, so used for specific soft tissue groups. So if there is pain in the neck, you are only going to check for the musculature within the neck first. So each and every area or segment needs to be checked at a separate diagnostic level, not together or not in alignment. They have to be separately checked. So the osteopathic protocol is TART, and those who have done my workshops or webinars know what TART is. TART, first T stands for tenderness. Asymmetry, what do I mean by asymmetry is, okay, if I am bending forward like this, is my right side moving equally and parallelly with my left side? So right back and left back, is it moving in the same plane or not, in together or not, in sync or not? That is what I am trying to check. Range of motion well, you now all know what range of motion means. And you take a goni, short form of goniometer or goniometry. You take a goni, measure it, bam, that's it. To me or to the school of osteopathy, that is not the end all be all. You cannot just quantify range of motion and leave it at that. You have to check for the quality of motion and then alterations in motion. What do you mean by quality of motion? So let's say if I am checking the range of motion for, elbow flexion, right? And I am doing this. If I, instead of doing this, I'm doing this motion, like a jittery motion, cogwheel type of motion, cut, as if someone has, rigidity, as you know, in Parkinson's. So if someone does that, that helps me understand that the quality of motion is not good. So quality of motion means how smooth the motion is. It does not mean the quantity of motion, because quantity gives me a range. Quality gives me an idea how smooth the motion is. Got it? Third thing, quantity, first cue, quality, second cue. Lastly, I have alteration, QQA. What is alteration? Alteration is this motion straight towards my shoulder, or is it coming inside and then towards the shoulder, or outside and then towards the shoulder? In essence, if the motion is in plane or out of plane, in plane or out of plane. If the motion is out of plane, I will mention that in which direction it is out of plane. So please do note, quantity, quality, and alteration is your motion is planar motion or biplanar, multiplanar, or whatever is the the variation in the plane, mention that or write that down. So those are the three characteristics of how to check range of motion. Lastly, tissue texture change. All right, now I am bending forward. When I am bending forward, and let's say you are my clinician and you are standing behind me, you are seeing my back. So if I am seeing the back, I have to check if both the sides of the back are at the same level or not. So for example, if one side is higher or the other side is lower, then there could be hypertrophy or atrophy. Hypertrophy or atrophy. So when I am bending forward, for example, I have to check the symmetry of either side to check if one side of the back is more prominent or less prominent to the other side. Then I know probably, and most commonly you will see hypertrophy, because the extensors or erectors are actually shortened and they contract and they kind of bulge out a little bit. So you will be, it's very, very easy to say, check for tissue texture change, and you will know that whichever problem area you have, that muscle is really inflamed, really engorged, and really like a balloon you can palpate in. And then you know that, okay, there is tissue texture change is positive and there is hypertrophy of that area. Now, jumping to ART philosophies. How can you do it? You can test it in different ways, all right? So different forces. Forces can be compression, tension, or shearing. So you can either test a tissue this way, you can test a tissue this way, or you can test a tissue this way, like as if you're grinding or sliding or gliding, that's shear force. So what does a clinician do? Uses deep pressure or tension in the area of tenderness, because you are applying pressure on the tender spot. That's the problem or the disadvantage of ART. This could be uncomfortable for the patient to bear, because you are actually accentuating a little bit of painful symptom. I always take pain as a symptom. Pain is not a diagnosis. To me, pain is never a diagnosis. If we think that way, then it is completely incorrect, because we all know pain has lots and lots of variables and factors involved. It has psychosomatic factors and socioeconomic factors, experiential factors involved. I'm not going to go into it, but there are lots of theories and postulates on that. You can take a look in your spare time what you mean by pain. And if you do, it'll take more than a lifetime to learn about pain, honestly. So coming back to full circle, the area of the tenderness, like as if it's a trigger point and you are checking the trigger point as you do, basically that compressive force is a similar technicality and how you check for trigger point. So patient is also instructed to actively move the injury site from a shortened to a lengthened state, from a shortened to a lengthened state, from a shortened to a lengthened state. So when you are stretching, you palpate that area to check for any adhesions, scar tissues, nodules, like you are seeing looking for a trigger point area. But trigger point is primary, there could be primary and secondary trigger points. And if you press, the patient will say, this may not be the case. It is just scar tissue adhesions we are talking of. May be trigger point, may not be trigger point. If it's not trigger point, this could also lead to pain. And then that could be the scar tissue or the adhesions. That it is not just the muscles that is completely entwined, but the fascia and other structures involved, everything else can be coming like a cobweb or spider web. It's not the muscle. That's a big difference between trigger point palpation and a palpation of adhesions or scar tissues. So essentially signs of scar tissue accumulation. Now, let's take a step back. This science is postulated by Dr. Lehigh around 1985, 1990. This is not end-all, be-all sign and symptoms. There are many other signs and symptoms that you know, I know, every one of us know. But this is what he believes in, and that's why, since ART is his philosophy, and that's why we want to focus mostly what he was thinking, or he still is currently, not he is currently, but the postulates are currently based on. Stiffness in your neck. So does that mean stiffness nowhere else is allowed? No. But if the most adhesions and contraptions, everything else is found in neck, elbow, hand, or back area, that's where the research on ART have found these are the key areas, not all areas, but key areas where you will come across more stiffness, or in terms of adhesions and scar tissue formations. Increase. So one of the signs is increased pain when exercising or during exercising. Sharp pain in the bottom of your foot, which nothing but means plantar fasciitis, right? Pain, numbness, tingling, weakness, that could be either a localized thing or systemic thing or completely neurological thing. So you need to know how to differentiate, take out the red flags out of the way, and then come to a conclusion. Oh, if this is a scar tissue or adhesion, does it still have pain, numbness, tingling, and weakness? If so, which nerve is compromised? So in this case, from ART philosophy, the pain, numbness, tingling, weakness is usually localized, or wherever it happens, down the chain, never up the chain. Down the chain, never up the chain, for obvious reasons, because from the central you go periphery, and if there are scars and adhesions, that basically blocks the vascular supply or the neural supply, obviously then you will have any sign and symptoms from there down the arm or legs. And then rest of the stuff I don't need to go through because that's very simple, right? Okay, treatment goals. Break up adhesions, restore range of motion, pain, restores pain perception, we all know. By breaking up scar tissues, so I am repeatedly saying something, that the philosophy or the treatment approach for ART is to break up scar tissue and adhesions. And chiropractors, Dr. Lehigh and other chiropractors, believe that most of the time soft tissues, bony, subluxation, you all know that chiropractors believe in subluxation mostly in the spine. And if there are any issues in the soft tissues, it is probably because of adhesions and scar tissue formations. It's not, again, only adhesions and scar tissue formations, but mostly it is adhesions and scar tissue formations. So I will actually go up couple slides and show you the osteopathic protocol. Since we have come down to the treatment, I just want to go over the examination approach a little bit in detail on my supermodel, who's my dad actually. So let me do it on him so that it is easier for you to understand. And then if you certainly have questions, feel free to ask. So give me a second and let's do asymmetry first, and then we will do range of motion and then tissue texture change. All right. In terms of asymmetry, let's say he has, a problem only on the right upper traps, and I found that there is probability of scar tissue or adhesions, basically chronic pain issue of the neck will certainly have, dysfunctional or derangement of the soft tissues. So for example, right upper traps is huge issues. So I will try and ask him to basically check his shoulder shrug. So exactly. So when he's shrugging his shoulders, obviously he's normal. But if there is asymmetry in terms of the height of motions, when the shoulder, the top of the shoulder is coming close to the ear, how fast it is going. One is going faster, or the speed of the motion is different or not, and also height of the motion or amplitude of the motion is different or not. That is what I am trying to gauge from asymmetry. Amplitude of motion, that's the height, and how the velocity of the motion or speed of the motion. That is exactly what I am talking about, asymmetry. Now, when I'm talking about range of motion, when he's, could you shrug again, Baba? So when he's shrugging his shoulders, I am actually checking for what? Not only just the quantity of range of motion, how smoothly he's shrugging, comparing side to side, how smoothly he's shrugging, and then if there is any asymmetrical or changes in the plane or not. Meaning, let's say if we are focused laterally, from a lateral standpoint, I have to check if the shoulder is not, make the shoulder go in from the front and then towards your ear. Go from the, not your hand, just the shoulder, like this, round it up. Round it and then go. Exactly. So if he's doing this, like a circular motion and then moving it towards the ear, since something is amiss, right? Something is incorrect. He's able to achieve it in the towards the ear completely like a shrug, but he's not doing exactly a shrug. You could tell me, oh yeah, that could be trick movement. Probably there is. I'm not saying it's no. But based on osteopathic philosophies or treatment, that is actually alteration. Alteration is motion, because that's the out of plane motion is alteration. All right. Lastly, tissue texture change. So why don't you stand over here, face that wall over there, and then let me show you from this angle. Probably this might be a good one. All right. And then I'll roll up your t-shirt, fantastic, and then a forward bend. Forward bend. So when he's bending forward, I'm checking this height. All right.
Sir, video ta ekটু বড় করতে হবে.
How I am trying to do, let me see.
Sir, just click on your video.
And now it's all gone. Now I'm not able to do it. I don't know why.
You can close your screen sharing. And done, sir.
Did you do it?
Done, sir.
Okay. All right. Okay. So let's say if he is bending forward, what I am trying to do or check is the height of the erectors and comparing it side to side, side to side. Is one side higher or the other side lower? Whichever side is higher, I am trying to palpate and feeling for the muscle bulk, if it is tensed or not, if it is, inflamed or not, if there are any color change, any kind of, temperature change, and everything I'm trying to palpate through that last point, which is essentially that tissue texture change. Are you? Okay. Thank you, Bob. Have a seat. No.
Sir, sharing off করতে হবে.
Sorry, what?
You have to screen sharing, switch off your screen sharing.
Okay.
Now it's fine.
Yeah, it's better.
All right. Okay. Give me a sec. Actually, I have to share the screen one more time. Okay. So we are essentially done with the type of examination what I'm trying to show you. Oh, actually, I did not show you the compression tensile one, right? That's a good thing. One sec. Let me stop share. Now, can I increase the screen size over here since I have stopped it, or how can I do that? Guys, anyone?
No, it's fine. Actually, now we are able to see you in the full screen.
Oh, fantastic.
Yeah.
All right.
Thank you.
So, what I was trying to show you is basically, all right. So the forces, it could be compressive force, it could be tensile, or it could be shear. So for example, tennis elbow, you know, tennis elbow, most of the pain is in the common extensor origin. So let's say over here is the common extensor origin. Right over here, I am trying to palpate. And then if I am pressing, pressing on the ECRB, common extensor tendon origin, and palpating, and then he says, I do have pain, that means that, okay, it is obviously tender area. So that tenderness or tart is basically positive. Now, with that, if I try to move the hand passively, or arm passively, and stretch the ECRB or common extensors, and again palpate, that is basically the fundamental principle of how you move the musculature and if the perception of pain changes or not. So that's the compression way of checking if the pain is really localized, if it is radiating, or if there is any other sign and symptoms that is associated with the compressive painful perception. Second is tensile, and with tensile we obviously mean essentially you are doing this kind of a rub from the periphery towards the painful area along the fiber line, So when I am doing this, going along the fiber line towards the common extensor origin, I am actually palpating on the ECRB from distal to proximal, With that, I can also do a motion for ECRB, essentially is extensor. So I am extending, which is a passive technique, or I am asking him, so could you also extend?
Excuse me, sir.
Perfect. Yes.
Sir, can you please switch off your screen sharing, please?
Give me a second.
Yeah.
Now, is that okay?
Yes.
Okay. So what I was saying is, in terms of the tensile activity, so you have to ask your patient to do an extension of the wrist to check for ECRB. When you are checking extension of the wrist, like this, do that extension. Perfect. When he is doing that, I am actually applying generous amount of pressure, which is under the control of the patient. I don't want to create too much of pressure, pain, that will actually increase the painful spasm of the muscle. I don't want to do that, right? I want to do a conservative approach of going deep as much as possible, or the patient is able to handle that pain. So tensile is doing an active motion of wrist extension. I am again pushing the ECRB towards the junction or origin or attachment point, and feeling for any sign and symptoms, any undulations of the muscles, any nodes on the muscles, anything that is abnormal. If the muscle fibers are not smooth, if there is a tear like grade 2 or grade 3 tear, there will be a slight bulge around the tear area. I can easily feel that bulge. If there is any tear, grade 2 or grade 3 or not, I can easily do that through the tensile approach. Now, lastly, which essentially is the shear, is a little bit different. For shearing, here, obviously you have to rest the elbow or rest the forearm on a table, right? Actually, do you want to do this? Why don't you sit over here and then rest your forearm over here? Fantastic. This actually makes more sense. Right. Thank you. All right. Thank you. Okay. So now you can see. So this elbow over here is all relaxed right now. So now I know where to palpate in terms of palpating the common extensor origin. So now, while doing a tensile stretch, when I do a tensile stretch, I know probably there are two origin of pain or tenderness traumatized area. So if there are multiple areas, I actually do, there are two ways of doing tensile. I actually do this on the ECRB while I stretch, while I do this with applying pressure, I ask my the patient to extend actively and then again do this when the pain is actually on either side of the muscle belly or muscle group, when on either side and I'm stretching and trying to feel it. The second thing is, if the pain is somewhere in the muscle belly, by surrounding the thumb along the point area of tenderness, if I again spread it, then again you extend the wrist, spread it like so, spread it like so. If I am stretching this area of painful spasm, then if the patient's pain increases, because if remember sign and symptoms, pain increases upon exercise or motion. If pain increases, you know spot on that that area probably has adhesions or scar tissues involved. Again, let me remind you, this is not the first test that you are going to do. This is probably after you do your basic history taking and analysis to rule out all red flags, you come down to a conclusion, okay, some problem is going on with the soft tissues. Let me check if there is scar tissue or adhesions present or not. So essentially that's what you are doing. Tensile, two-way, two painful points, I come in between and stretch it towards the painful point. One painful point, my fingertips are actually surrounding the painful point and then stretching the painful point in either directions along the fiber line, resulting in basically your painful spasm or perception, and the patient will say ooh ah, right? Okay, let me share the screen one more time and check where we are. All right, we got to compressive tensile shear. Fantastic. All right, let's go ahead and do some treatments and then we'll call it a day. All right, give me a second. You just wait over here, Baba. Okay, we were actually on treatment goals. Art philosophy, that is exactly what we talked about, involves very precise pressure. So when you are applying the pressure, usually in the courses that I have done with them, what they usually say is your pressure needs to be halfway between the thickness of that muscle belly, because that's the most prominent area where you have scar tissue and adhesion formation. So that's the reason. Can be very painful, as I said, because it's a tender point. It's a tender area. So the disadvantage of ARC is you may not be able to use it on individuals who have low pain threshold or tolerance. That's the third bullet point, because the treatment or the diagnostic session could be uncomfortable. But if you are able to work it, you can actually make the tissue, break the scar tissue and adhesions in as little as one session, or though obviously some may need more than 1, 2, 3, 4. Whoever needs more can have more. All right. So now in terms of the diagnostic principles and treatment. Static, what do you mean by static, passive, active, dynamic? Because static, how can it be active? All right. So for example, if I ask my dad to actually hold, I will.
Screen sharing. Sir, turn off your screen sharing.
Yep. I remember. All right. There you go. So now, what we are talking is static. So basically, are we doing static? We have to do it either passive or active. Then we'll come to dynamic. So static is positioning any part of the body segment at one place and you are holding it. That is static, but passive because you are holding it. And then active is essentially the patient is able to hold the same position or not. You can have it as a muscle contracted phase. You can have it as a muscle completely lengthened phase. When you do, how you do and what you do is what we talk about in my workshops. That because there are protocols that we follow, as I said, there are close to 80 protocols and 500 motion sequences. So in my workshops, I talk about those protocols, when to do what. But overall, globally, you can have passive or you can have active for the same position, but static at one place. So you can keep the muscles in the shortened phase, in the mid-range phase, or in the completely lengthened or stretched phase. So you can do multiple permutations and combinations of motions either in static or in dynamic phases. And dynamic obviously is, let's say for example, you can do it passive, you can do it active and assisted, he can do it himself active, and I can also resist the motion throughout. So you just lift it, Baba, and I'm resisting it down. So in all these motion sequences, I am able to evaluate accurately, precisely, and locate where the problem area is, in which muscle group, and in where exactly in the muscle group I can easily palpate based on these principles. Also, what I don't have in my slide, and I just said it, you can either do the static phase in muscles that is shorted phase, muscle that is in mid-range contracted phase, or muscle that is completely stretched, elongated, or lengthened phase. You can do it in 3 phases. And for dynamic, obviously, it is going from the shortened phase to stretch phase and from the stretch phase to the shortened phase. So it does not make any sense in terms of lengthening or the, the distance of the musculature origin and insertion, right? It does not make sense. So these are the values or principles that ART follows in terms of how you can guide motion and then locate precisely where actually the problem area is. All right, let me share the screen one more time. Okay, so now we talked about principles of diagnosis and treatment and like treatment ideas. This is what probably you have been waiting for. All right, for scalenes, one of my favorite muscles, favorite muscles, those who have neck pain. I mean, the number of neck pain individuals with scalene contracted, tight, adhesions, scar tissues, whatever definitions and name you can give, scalenes will be a huge big culprit, because you know that the term origin and insertion is actually getting obsolete. It's actually proximal attachment points and distal attachment points. The proximal attachment points are the transverse processes of the C-spine, whereas the distal attachment points are first rib and obviously the second rib too for the posterior scalene. So I will give you very briefly some treatment ideas for all these 6 musculature. Let's start with the scalenes then. So I'll stop sharing, and then if anyone can tell me what the next muscle is, then I don't have to again come back to it. All right, Dr. Kaushik Malli, still let me know what other muscles that we will have to do. Okay, so scalenes. For scalenes, turn over here. There you go. Remove your glasses. Always remove glasses, because you never know what can stick in the patient's head or ear, and then it will be a painful problem. All right, as you know that this guy from the mastoid process right over here is the sternocleidomastoid or SCM. Scalenes, palpation towards the origin or basically the proximal attachment point is just posterior to the SCM. But while you are coming down, you have to cross SCM in front, because your first rib attachment points is anterior to SCM. So you essentially have a diagonal pattern from proximal attachment to distal attachment. Proximal attachment over here to distal attachment. So how am I going to do the ART? I use either 2 or 3 fingers depending on many characteristics actually. Patient's height, patient's girth of the neck. If I am able to push the muscles that is very tight with 2 or 3 fingers, so there could be many variabilities why I can choose 2 fingers or 3 fingers. So essentially, let's say since my dad does not have any issues, so I will not going to press on it. This is the positioning. Seated, neutral, normal head posture, no chin tuck, nothing. I will actually guide the head again, through my hand on one the problem side and the shoulder on the other side. So I'm kind of locking or hugging the head between the shoulder and the hand. While doing this, I start from static, even though it is active release technique. In my experience and what I have come across in the different workshops that I did in US is that you start with static release technique and then go in for active, then it is easier for the patient to handle the pain. All right. So I do this, either 2 or 3 fingers, press and feel for the motion, stretch it. If the patient tells me the pain is more or less, doesn't matter. The philosophy is from a contracted state, you have to go into the elongated or lengthened phase. So I am flexing with the ear coming to the same side, where same side armpit, ear to the same side armpit to contract the scalenes and use my 2-finger technique from the posterior to the SCM. While in the stretch position like so, my finger is actually going deep down and coming in front towards the first rib. You cannot palpate second rib. Maybe in petite individuals, in females who are a little bit on the leaner side, like size 0 probably, then probably you can go down deep into second rib to palpate for the posterior scalenes, but usually you will not be able to palpate the posterior scalenes. So this is essentially from the contracted phase, I am stretching it as pain permits, and then basically pressing it and going down deep along the fibers. Now, you could say that, oh, this though I know, I have done that. Again, this is a webinar of 1.5 hours. I am not doing any protocols or the motions. This is one of the 500 moves that or motions of the muscles that we can actually perform based on the ART. So there are variations, levels, complexities involved. As if you are, if you are interested in that, you can certainly contact me and we do that in the workshops. This is essentially what does level 0 is when someone comes to you and you do this. Test it from tomorrow. Tomorrow is a new day, Monday, new week. Test it from tomorrow and you will see the change. You don't have to tell me. You see the change and then you have to, thank yourself essentially and the patient for doing that. So that's number 1. Number 2, I'm not sure. Oh yeah, Levator SCAP. So for Levator SCAP, since you know Levator SCAP, one of the distal insertion is the superior angle of the scapula. From there, it comes right to the spinous processes of the C-spine, and in some cases T1-2. So it is this is how it is angulated. So contracted position is this at an angle. So right side but an angle. So what is the stretch position? Stretch position is chin towards the opposite armpit. Chin towards the opposite armpit is the stretch position. And where will you apply? Just on the tip of the superior angle of the spine. You press and then move along CT junction or maybe C6, C7 spinous processes and do the from the contracted state, the extended or the elongated state like this at an angle. So from here to here, opposite, chin towards the opposite shoulder, and do this motion with that. That's essentially how you do the stretch for the levator scap or release the contracted levator scap stretch. All right, I think we have quadratus lumborum and psoas. I'll show the psoas first, and then I'll show the quadratus lumborum. So Baba, you have to head over here, leg over here, on your back. Okay, let's do this. Now, this might be a little challenging, but let's see how we can develop this. Let me see. I'm not sure if the angle makes sense to you, but we'll see. So this is for psoas. Psoas essentially is, let me hold on to it. Psoas, so you find the rectus abdominis from the lateral portion of the rectus abdominis at a 45-degree angle with exhalation of the patient, with the use of 2 or 3 fingers, you have to go deep in, like this, go in. Probably by the end of 3 breaths, exhalation, you should be able to palpate psoas major. Remember, 8% of the population do not have psoas minor. They do not have psoas minor. Psoas minor, if you have done dissection of cadavers, you will see psoas minor is very thin, very flat. It doesn't have that much of a function at all. So psoas major that's how you will essentially palpate. Once you palpate that, you make sure that the leg is relaxed. So the leg is usually up, flexed, and outside, flex and outside. So this is essentially the positioning. There you go. And from here, you penetrate through the lateral part of the rectus abdominis into the psoas major. And then with the help of that, you can essentially glide your fingertips from the proximal point or the origin, proximal attachment points of the psoas to the distal attachment points. Remember, you will never get to the distal attachment points. Hopefully you remember where the distal attachment points is. Lesser tuberosity. If it is lesser tuberosity, how can you get into that? Because you have your inguinal ligament that will cover. So essentially from the proximal attachment points, that is basically your transverse processes of your lumbar spine, you can go dig deep in and come to the inguinal area and you can release the psoas. Most individuals with low back pain will have problem in the psoas major muscle. It could be hypertonic, so you have to release, or it could be not hypotonic, essentially means there could be a laxity of that or underworking psoas major. You have to activate that. So there are different ART protocols that we follow to either activate the muscles or release the muscle. What I just showed you is releasing the muscle in this direction, from the proximal attachment points towards the distal attachment points, keeping the knee flexed, and outside or more externally rotated. So that's for psoas. Similarly, for quadratus lumborum. So for quadratus lumborum, again, a big muscle that is extremely painful and problematic in low back pain. Also in mid back to upper back pain, also quadratus lumborum, which essentially attaches to 11th rib, 12th rib, and obviously the thoracolumbar fascia has a huge role to play in that. All right, so right now my dad's basically side is on the left side is up. Quadratus lumborum is usually on the anterior side of the iliac crest. That's where the distal, not the distal, that's actually the proximal attachment point. So what we call or you call as origin is down over here, and the insertion is up on the ribs, 11th, 12th ribs and the thoracolumbar fascia right over here. So this is how it goes. Now why side lying is best for QL palpation? Because all the organs are gravity assisted. They are towards the floor right now, like hanging towards the floor. It gives me a lot of space, and also the transversus abdominis, which either would have been very tight, is now also relaxed. So since the transversus abdominis is relaxed, I can actually go through between the iliac crest and the 12th rib, dig deep in and palpate quadratus lumborum during exhalation. So probably by the end of 3rd or 4th exhalation, I should be able to palpate the QL. Once I palpate the QL, I can stretch by holding on. I can stretch by holding on to the iliac crest and pulling it down. Iliac crest and pulling it down like this. I'm exaggerating. This is not how I would do it, but I'm exaggerating. This is how I do it, okay? So stretch it. Once I stretch it, I use 2 or 3 fingers, dig deep in, and then use my fingers to do this on the QL. Maybe for 90 seconds to a minute, 3 times, 3 repetitions, and maybe 2 sets, 90 seconds, or maybe a minute, 60 seconds, 2 or 3 times, 3 times, and 2 sets I do to release the QL in this position where I know it opens up this space, the lateral part of between the abdominal cavity that is at the border of the 12th rib and the iliac crest, which helps my fingers to poke through the transversus abdominis. And obviously you have your external obliques and internal obliques, but they are very thin. If you have seen cadaver or dissected cadavers, you know internal and external obliques are so thin and so intertwined, it is very difficult to separate them, and it's also very difficult to exclude them when you are dissecting, because they are stuck together like glued Fevicol adhesive. So this is how essentially we dig deep and palpate for the QL. All right, 1, 2, 3, 4. Okay, what else do we have? Do you remember? Who else is there? Probably not. Let me share the screen and check what else we had. Okay, plantar fascia, yes, and probably one of your guys' favorite, because you need to know plantar fasciitis. All right, for this you can lay down. All right, fantastic. Okay, this is easy peasy, and then we'll actually end. So it's already close to 1.5 hours, but we had some delays. So hopefully you are still hanging there with me. All right, for plantar fascia, right over here. This is not a good position, but in some cases I have to do this to show you, but I would probably sit on the foot end and flex the knee joint so the foot actually crosses on the other leg. That is mostly relaxed position for the plantar fascia and plantar intrinsics, the intrinsic muscle. So what I essentially doing is because the skin thickness of the sole of the foot is so thick, it is difficult for my fingers to point. I probably will have arthritis in no time. So I use my thumb, palpate on the base of the calcaneum, right where the plantar fascia is kind of originating, press it hard, and with the help of that, what is the active part of it? With the help of this, I ask the patient to extend the toes, So I start by doing extensions passively, then I do it active assisted, then I do it actively, and then I do it resisted. So the same motions of toe extension and foot dorsiflexion, I do it in this thematic protocol. From passive, active assisted, active, and resistive, I do the exact same thing. And what I do with the other my thumb, I press from the base of the heel of the calcaneus, come up in different directions, because if you have seen foot cadavers, they start over here, but obviously they spread on the 5 toes. They spread like this. So from here, I go once in this direction, once in that direction, once in another direction. So I do it in 5 ways, and trust me on this. You do this active release, like 2 or 3 sets, you will see how much the patient will thank you. And the pain, again, a symptom. I don't like to call pain because there are certain pet peeves I have. I don't like to call pain as a diagnosis, since it's a symptom. I said motion. The motion will extremely improve, and the strength of the plantar plexus will also be released and improved also doing this kind of treatment. So you are essentially pushing it in different directions of the 5 different areas. And that's how basically you do plantar fascia active release technique. All right. I actually need to thank my dad. Thank you for holding up. I think we are good. Thank you. All right, let me share the screen real quick so that before we end it up. So scalenes, remember scalenes are over here. Any muscle, it is not just these muscles that you can treat. I just gave you a little bit of principles. You keep it from a contracted face, shortened face, you take it to a lengthened face and use your fingertips to go in from point A to point B, origin to insertion or proximal attachment point to distal attachment point, and really cleanse the essentially the track or the root of the muscles. And you can do it for every musculature in the body. FYI, please remember, these are very good for localized pathologies. If it's a generic thing, ART may not work how it should work. They work very good for localized pathologies. If there is a problem in a specific local area, then go in with the ART, because no treatment is perfect. What you have is a box of tools, different varieties of tools, like a carpenter's box, right? They have different sizes of screwdrivers. You have different tools because one tool may fit one patient, that same tool may not fit other patients. So what I'm trying to give you, that's why treatment ideas. As I said, I don't want to spoon feed you. These are ideas that you can, use it and then apply in different settings for different cases and, patients. Okay, what next do we have? Treatment take-home message. So essentially, after you go home, you come back to the YouTube video. These are the things that you need to know. What are the benefits of ART? What are the signs and principles? So essentially, examination, evaluation, and the treatments are similar. That's a great thing about, conservative pain management techniques. The manual therapy, as you say, the examination is the treatment is the examination. But please don't forget these two things: test, treat, retest. Always remember this: test a segment, do your treatment, and retest the same segment, just to check if everything is what it should be. Also remember, mobility, stability, controlled mobility, and function is the basic premise for exercise principles or home exercise program. But you can start with mobility or stability, but then if you start with stability, then go in with control mobility and function. Or if you start with mobility, then obviously go in with stability, control mobility, and function. But never, hodgepodge everything, because that messes up the brain's neural network and motor control. Then the patient will either come back to you or probably go to some other, healthcare professionals to take advice for their pain. So here are some of the resources I have taken, but it's not end all, because obviously since I have taken all the courses, I had some other resources that I have used also. This is my contact information in case if you want to learn more or have more information, please go ahead and do. And so I will take the time to get your questions answered. So I'll stop sharing and then I will ask moderator Dr. Kaushik Mollik to,
yes, sir. First question, can ice be applied?
Like what? What do you mean ice be applied? Like, I don't know why. Okay, let me think about it. What do you mean by ice applied? I don't know, but hopefully I can get the drive of what you are asking. Ice post-injury is my go-to. Heat is not my go-to post-injury. Let's say if a patient comes to me for after 5-6 days of neck pain or after 3 months of neck pain, I always tell them to ice the first time they go back home, because not because of this, just because of the state of the injury condition, but after I do a manual technique, there will be tenderness because I'm using my fingertips and thumb to poke through soft tissues. And if the neural sensitivity is really hyper, it's more, then it is always important to hypo, make it desensitized. And you know that icing is one of the best desensitization protocols. All right, next question.
Contraindication and precaution.
Yeah, well, contraindications are same for any, conservative healthcare treatment. There is no certain contraindications. If you are able to judge correctly a diagnostic feature, if your diagnosis means that, yes, there is scar tissue adhesions present, you go ahead and do it. If there is no scar tissue or adhesion, don't do it. That's it. There was a second part to it, contraindications and what?
Precaution. Precautions.
Precautions. That's a great thing to do. Precaution is essentially take care of the signs and symptoms. And for that, what I mean by signs and symptoms is pain and tenderness. See to it that when you are poking through on the tender point, you maintain the pain at the threshold of their perception. If it crosses that perceptible, area, then there will be too much pain and probably the patient will not come back to you. So there is a little bit of a give and take. When the patient understands what you are doing, when the patient, has the belief or the trust, gain the trust on you, then I think it is easier to go in depth and then wiggle or, tickle the painful area a little bit more. But overall, precaution other than this, I don't think there is anything else in other than the manual therapy world, basically. So nothing off the book. What else?
How can we palpate psoas muscle?
Just as I showed, so you have to essentially flex the leg on the same side, then basically make it rotate externally, use 2 or 3 fingers, go at 45 degrees lateral to the rectus abdominis, during exhalation poke, during exhalation poke, go by probably 3, not even 4, 2 or 3 exhalation, you should be able to reach the lateral border of the psoas or anterolateral surface of the psoas. You should be able to reach. In fact, in some cases, like I do have a patient right now who's coming, a young guy. Since he's young, I can actually feel the aortic pulse because that is extremely close to the psoas structure, abdominal aorta. Remember, you can feel the aortic pulse like it is really powerful and you can feel that. So that's basically how you palpate psoas major. Yes, please, Dr. Malik.
Can we start MFR on first day?
MFR on what? On first time?
First day. On the
Yeah. Yes, like you should. Like School of Osteopathy, that's a great question. Thank you for that. School of Osteopathy prefers or likes you to go from outside to inside. So obviously bone and joint are completely deepest. So the most superficial is the fascia. It's not that fascia is only present superficially, it is completely entwining. But when you are going from up to down, gross to microscopic, you certainly should be mobilizing fascia. That's my go-to. That's like probably 80 to 85% of the time, if any chronic mechanical dysfunction individual comes, I go in with fascial techniques, and there are zillion numbers of fascial techniques, and you can use whatever you love to do. In fact, you can also use dry needling and cupping. What else?
Can we use in frozen shoulder and take care?
Like ART?
Yes.
Right? That's frozen shoulder. You have to use ART, and I'll tell you the 3 muscles. If you treat those 3 muscles, your patient will probably hug you with that frozen shoulder. By the end of the day, they will close to have near normal range. Mostly in the elevation plane, not much in the rotation. Rotation takes a little time, but elevation, I get it in one day, like 160, 170. That's not a big deal. You have to release latissimus dorsi. Write it down if you want to remember. Frozen shoulder release, latissimus dorsi, subscapularis, pec minor. These 3 are staple diet, like chawal, chapati. These 3 muscles are staple diet. Latissimus dorsi release, subscapularis release, pec minor release. You get it. If you know how to release it, you will easily get it very clear. No problem at all.
Can static or dynamic technique be used at the same time?
Like in sequence, yes. In sequence, yes. Simultaneously, no. But that's again a nice question for me to repeat myself. I always start, if it's a very first day or a very first time, I start with static and go with dynamic. And in dynamic, again, I follow the protocol of passive through resisted. But if the patient is coming for n number of days, for me, actually the patient, I every day, neither I keep patients more than, I don't know, 10 days probably is the max I keep. But within that 4 or 5 days, I can actually jump into based on the base. There are again protocols that ART follows. Based on those levels of the protocols, if I palpate and feel that the muscles have gained the level of physiological structure, I feel like, again, it is a little bit subjective, obviously. But you have to hone in the skill day in, day out, and you can certainly do that too. Then yes, I can jump into dynamic state of right instantly and not go. But first day, I do it static. Next.
Diagnose, treat, and radio diagnose ICE in which phase?
Let me rethink about the question. ICE is actually at home. Either you can ask your patient to apply ice and then come to you, and for sure, never ever, at least I don't forget, I doubt anyone in US forgets. Doesn't matter if he or she is a PT, chiro, osteopath, always ice after you go back home. Always, always, always. I never forget that, even in India. I don't forget. I always tell my patient, go back home, give a 20 minutes ice pack, and then you should be good, because I know I have used my thumb and fingers. It will create some amount of tenderness. So, and I don't want the patient to think that the pain has increased by just by that. It does not, but it's just the fingertips because you are doing it manually. So ice before and for sure after, but during, why would you waste time for during the process of it? Yes, next.
Is ART and trigger release similar, sir?
Yes, again, great question. It is similar, but trigger point, as the name says, is a trigger point on the soft tissues. ART is very much focused for adhesions and scar tissues, not just trigger points. Hopefully you understand the difference. Adhesions and scar tissues and trigger points, both ART can work, but trigger point therapy is only for trigger point and not for adhesions and scar tissues, because it's very fascial oriented. All right, next.
How do we apply ART and acute neck spasm?
You have to do workshop for that. As I said, there are 3 levels and there are multiple protocols for the neck pain. But as I showed you, you can do the Scalene release, you can do Levator SCAP release. These two, what I showed you is essentially level 0 for both. So you can do both treatment at the first time to reduce neck pain. And I get awesome result with the Scalenes. And I have not showed you the second and the third level where you have to inspire, you have to resist inspiration and expiration. There you can change tidal volumes and stuff, you know, inspiratory reserve capacity, and change the muscular activation patterns. Those are very high level, but we do it in the workshops. All right, next.
Any particular tools used except finger?
Any particular what used?
Tools.
No, that's a great question. Probably we should to, you know, relieve our fingers and from our thumb from having arthritic changes. But unfortunately, Dr. Lehigh, when he postulated this, philosophy, he said your thumb and your fingertips are your eyes to the body deep inside. So you should not be using any tools to manipulate structure, because otherwise how will you feel for that? So he does not recommend, but that's not my recommendation. I actually use some of the tools I got from US. So I do use, especially for plantar fascia, I use those tools to help me. Those are not ISTM tools. They are a little bit of a different types. But anyways, yes, you can use. If you want to, go ahead and use it.
Is positional release technique the same as ART, or it's
no,
different?
It is not. Positional release technique is grounded on strain counter strain. So that the philosophy of strain counter strain is different because it uses muscle activation potentials, but ART does not use muscle activation potentials, and it is the active part is just to stretch from the contracted position. It is not a strain counter strain where you are resisting it. It is not a resistance. You are forcing the muscle. You are using palpation and fingertips to stretch the muscles and elongate the muscles. You are not doing like a sacral release through strain counter strain measure. You are not. So it is not completely on the contrary. Next.
So we can apply ART in severe tightness muscles?
Yeah. Yes, I mean, you do your ARTs as I showed you from shortened to lengthened position by using your fingertips along the muscle fibers. Even if you don't do ART, even if you don't do any workshop, you will still be able to get good results if you follow the basic premise that from shortened to lengthened, use 50% pressure of the thickness of the musculature or soft tissue, and then use it parallel to the muscle fibers. You will certainly gain good results. I mean, for the Scalene, so like you start from tomorrow, and you can, if you can tell me later on. So
what is the treatment for FMS as it's not localized?
What is the treatment for FMS? FMS? I am not getting what FMS is. That I don't know what acronym is. I just don't. You have to explain it to me. Sorry. Next.
Difference between scar tissue and trigger point.
Oh, as I said, scar tissues are essentially usually after trauma or injury, overuse, repeated use, micro trauma, whereas trigger points, it forms a nodule where you have nervous, collection. Nerves are basically hypersensitized. In scar tissue adhesions, you usually do not have neural input much because it's more fascial and soft tissues within which they are the collection. There is a intertwining of actin, myosin filaments and other fibrous tissue, whereas trigger point, obviously, as you know, is very muscular and you probably have nervous tissue. That's why you have sharp shooting pain. In scar tissue adhesions, you will probably not have sharp shooting pain. What else?
Thank you, sir. No more questions.
All right. Okay.
Now I would like to call Dr. Isiraj. Please say something. Dr. Isiraj.
Yeah. First of all, good evening, everyone. I would like to thanks Sanjay Sarkar sir for conducting webinar for IIP State West Bengal. Today topic is very different from other topics. Today we learn lots of new techniques. So hope everyone learn new techniques. So I would like to again thank Sanjay sir for conducting this very good webinar. Thanks, sir.
Thank you. Thank you.
Now I would like to say something. Dr. Masrat Safi sir, please say something.
Good evening all. It's very late, but the important thing is that the speaker is so energetic that he has kept everybody awake, and not even a single moment that you can take mind of, because all the time he is giving all the energy. And regarding the speaker, I will say there are some people who will have a lot of knowledge, but what you can gauge from is the way you use your hands and the techniques. The way he was working on the patient, it is like he was having excellent knowledge of what he is doing, and he has been doing it for a very, very long time. One thing I will concur with him is that our hands in manual therapy, they are the eyes. And literally sometimes what we do is we literally close our eyes to feel the moment. So a beautiful lecture by him and a beautiful presentation. Also, sir, your dad, a wonderful agile person, a wonderful model that you have found today.
Thank you.
Say thanks to him. And
Thank you.
from my side, congratulations to Dr. Rishiraj, IIP CEC East Zone, Dr. Kaushik Dey, President, Dr. Arvindam, my old friend, and Kaushik Malik sir, Vice President West Bengal, who's very active and doing all these activities. All these days, I will tell all the participants right now, believe me, people have spent a lot of money trying to learn few techniques. But these days, with all these webinars, you are getting some things which you will never dream. You will have to travel so far and so wide to learn these techniques, but you are literally getting them for free. And it is for you to learn and hone your skills and make yourself better professionals. And again, congratulations to the West Bengal team for finding such beautiful and wonderful speakers who have well versed in their subject. Again, thank you so much for having me, and congratulations to you all for a beautiful presentation and a technically sound presentation, I'll say.
Thank you, Dr. Shafi.
Thank you, sir. Now I would like Dr. Arindam sir, please say something.
Thank you very much, Sanjada, for your nice and informative presentation. Thanks, Safi sir, for coming here. Give a moral support to us.
Always there for West Bengal.
Thank you, Rishi. Thank you, Dr. Kaushik, for organizing such a nice webinar for all the participants. And lastly, I thanks to all the CEC and IIP technical team to give a nice support to the IIP West Bengal branch to organizing such informative webinars. Thank you very much to all of you.
Thank you. Thank you, Arimnanda.
Thank you.
Jaspreet ma'am, please, up to you.
Okay. Thank you so much, sir, for such nice and informative session. I hope every participant acquire knowledge. Thank you, Kaushik sir, Rishi sir, Anindam sir, and Tanushri ma'am, and whole West Bengal team for organizing such wonderful webinars. Now, I would like to thank Sanjeev Jha sir and Ruchi ma'am for providing us this platform. Again, I request to all the participants, please like and subscribe IIP India YouTube channel and Facebook page. Thank you so much and good night, everyone. Shubh Ratri.
Thank you, ma'am.
Good night. Thanks.
Good night.
All right. Thank you. Good night.